Welcome to the Senior's Choice Caregiving Training. This training video is set up in such a way that it'll cover all the bases, or many of the bases, for giving great quality care to our clients. And it's my privilege today to introduce to you somebody who will share with you this information. My name is Peter Drubay. I'm one of the executives for the Senior's Choice. And in our efforts to work with some of the best caregiving resources in the community, we came across somebody that we were truly impressed by. We came across somebody originally that introduced this person to us, who told us that they were already an expert in caregiving. And we asked this person, her name was Jane, we said, Jane, well, how is it that you're an expert in caregiving? Do you have a background in nursing? Have you been giving care for many, many years? And Jane said, oh no, I attended this course. It is the best course of its kind as far as caregiving goes. And we thought, well, we need to find out about this course. We have so many of our members that would really greatly be benefited by attending a course like this or having their employees attend this course. So we did the investigation and we came in contact with an individual that we have found to be truly remarkable in her skill level. Her name is Celie Adams, and you'll meet her in just a moment. She'll be conducting this course for you. Celie Adams is a registered nurse and has worked in virtually every area of the nursing field. She, in 1987, started a nonprofit organization specifically geared towards teaching caregiving. She and a partner have been running that for many years, and it's currently the Center for Caregiving Training. It is located in San Francisco, and over the years she has trained many, many people for caregiving, but has also been the recipient of many awards in the process. Some of the big ones include national awards that ranging from the Rosalind Carter Caregiving Award, all the way down to local things in her community. She's actually had the Celie Adams Day in San Francisco, which has been fairly fun and impressive for both her and for everybody around her. I think what you'll find by going through this segment today is that she's somebody with a tremendous amount of knowledge, somebody that you can benefit from, and most of all, she's somebody that cares about the people that we care for, and somebody that will help you care for them more effectively. So, without further ado, let me introduce to you Celie Adams.
Well, good morning, everybody, and thank you very much for being here. And I want to thank you for inviting me to be here. Today is Pick the Nurse's Brain Day. I am here to be a resource for you guys. So I want you to feel free to have a dialogue with me throughout the day. My background for the last 14 years has been training family caregivers. That's what the Center for Caregiver Training was really all about. So I am kind of shifting gears here a little bit to talk to you about people who will be incorporated into families, and they will become like family members, but they do have constraints because they are the hired employees of people. So kind of bear with me when I shift gears once in a while. What I hope this can give each and every one of you is some food for thought. What I thought would be a nice basis upon which to build is to talk a little bit about the aging adult, of which we all are. So if this makes you a little uncomfortable as we talk about our futures as older people, yeah, I understand if you need to leave the room and grab a box of Kleenex. What we're going to really focus on is mostly about the physical changes of aging. That's what's going to drive people to be calling you to say, you better send someone over to help me. There's some real interesting stuff out there right now about aging theory. In Marin County, we have this mega $1-million institute, the Buck Center on Aging, that kind of sits up on this hill. And they do just some of the most interesting work. I sat at a lunch one day and at a seminar, and this guy comes in with these pictures of these little worms, little earthworms, and talked about how we had this aging earthworm that was really kind of shriveled up looking. He wasn't really in good shape. And then he showed this same earthworm after they had treated it with all of these kind of antioxidants and what have you. And we had this glorious looking little, plump and juicy earthworm there. And his premise is that we don't need to age at all. and that animals in the wild don't age. And of course, my first thing was, well, they get eaten before they get old. You know, what do you mean people don't age? You live long enough, you're older. But, you know, they have this whole other theory, and as they're doing the research, there's some stuff coming out that looks pretty interesting. Any of you read The Wrinkle Cure yet? Oh, everybody needs that book. Yeah, he's talking about reversing our faces, pulling everything back up without facelifts, you know, so if you need The Wrinkle Cure, you need to read that. And it's all about antioxidant therapy. Apparently there's these things in our environment that cause us to make in our body things called free radicals. We're not talking the Black Panthers here. We're talking about these chemicals that destroy cells. These oxygen, hydrogen, compound chemicals that are really what causes our cells to break down and wrinkles to happen and all that. And of course, the reason that we get this cell damage over time, first and foremost, radiation exposure, so wear your sunscreen, okay? And it should be actually a sunblock, not as just a screen. And the other thing is the bacterial illnesses and the viruses that we contract over a lifetime. And some of those which our body is able to, you know, pretty much control and get rid of the infection, which happens to some people with certain kinds of hepatitis every time we have the flu, et cetera. But then there are those things that people end up having to live with. There's viruses that end up, you know, sitting in the valves of our hearts. And so later on in our lives, gradually over time, our heart valves don't work real good. So those are some of the things that contribute to the aging process. And then the other thing that happens as we get older is the different ways that we lose the ability to get rid of body waste products. And of course, we think most obviously about urine and stool, but on the cellular level, every cell does its job and it takes in nutrients and then it excretes out stuff that is the byproduct of its metabolic process, and that has to go out in the bloodstream and is gotten rid of through sweat from our pores, the carbon dioxide coming out in our lungs. And sometimes those things are not happening efficiently as we age. And if you smoke over a lifetime, that changes the ability to excrete carbon dioxide from the lungs and take in oxygen into the lungs. So all of those things contribute to the aging process. And as we age, things change in our immune system. There's lots of research that shows that we lose the ability to really ward off diseases like we used to. And the other thing that happens is things that we lived with for a lifetime that normally didn't cause us problems, all of a sudden we develop an allergic reaction to them, which further damages cells, and we get what's called autoimmune reaction. That can happen, for example, they think arthritis is where all of a sudden our immune system determines that something in our joints is a problem and actually mounts a defense to destroy it against our own tissue. That's kind of the underlying reason that people have, like, the disease lupus. It's that our own immune system identifies their tissue as foreign and mounts an immune response against it and destroys that tissue. So that happens in aging. To some people more, other people less, but that's part of the aging theory. Now, let's go through it system by system, and we'll talk about how each of these different body parts change. This is, believe it or not, an eyeball. Looking sliced through here from the top down. Now, we all know that our eyes change after the age of 40. We start getting farsighted. You notice when people will say, my arms aren't long enough when they hold the book or the newspaper or what have you. So that's because of changes that happen in, this shrinks down closer to this. You see, there's this wide area, well, that gets narrower, and that changes our ability to see. the implications of that for older people is it changes their depth perception, which means that they get trouble like tripping with trips and falls. So it can be a safety issue in the home, this changing. And if they get corrective lenses, and any of us who have already gone to bifocals, and we don't want the line for the bifocals, so we have this hazy area where we have to learn to adjust. The older a person is, the more difficult it is for them to move that eye to look down to the places they need to. And when you look down to see the floor and you go through the part that helps you see close up, it changes where that floor is and where they're going to step. So the accident ratio in the home goes up with these vision changes. Another thing that can happen is cataracts. Now, if you've ever looked at anybody, you ever seen anybody with cataracts? You looked in their eye and you see that foggy where the black is, it looks cloudy. And that's this right here. This is the lens of the eye where the light comes through and we actually see the image and the light comes through and bounces off back here. Well, this gets cloudy. And there's a lot of research that says that that's probably because of sun exposure, which is why you're now noticing that all the glasses you get, whether they're clear or sunglasses, have the UV protection coating on them, because cataracts are a result of sun damage. Now they can take that cataract out, they pull the lens right out of there. When they have eye surgery, they go in through the cornea, pull the lens out, and they now make plastic lenses to replace them that they pop back into the little capsule that fits in, so that people maybe do not have to have too much correction in their glasses. Or for people who, for whatever reason, cannot have a lens implant, then they get those incredible Coke bottle glasses that they have to adjust to so that they can still see. And as you can see, think about, these all have implications for falls in the home. So if you happen to know somebody's got new glasses, you watch them till they get used to the new glasses, because they could trip and fall. There's also glaucoma, which starts at middle age and can progress. That one's scary, because glaucoma, there's really no symptoms for it. There's no pain. What happens is, for some reason, the eye cannot drain the normal liquid. We have tear ducts and what have you, and there's a flow of fluid in the eye. And for some reason, that fluid can't go anywhere, and it keeps building up in there. And you can see this is a confined capsule with lots of really delicate nerves all back here that are responsible for our vision. That's where we see, is in the back of our eyeball. And if you keep creating pressure inside there, pressure on those nerves kills those nerves over time. And then the person can end up blind. And there's treatment for it. I mean, it's pretty simple. There's a couple of surgeries they can do now to help with the drainage, or people use eye drops. But people need to get regular eye exams. Each one of us in this room, every 2 years, needs to have our eyes checked, and it's that little, they blow the puff of air in your eye to check pressure. And that's how they tell whether you've got glaucoma or not. One interesting side effect about medical marijuana, it reduces intraocular pressure, and it's a good treatment for glaucoma. So, if you're on the medical marijuana bandwagon, this is a good excuse to smoke dope. There are also medicines that will cause drying of the eye and blurred vision. And most of those are in over-the-counter cold remedies, which all of us use. And people who are at home who get colds and flus, and they're probably in the habit of using those too. So people who are complaining of blurred vision and they've been on cold medicine, that might be what's happening to them. So people need to pay attention to what their over-the-counter stash is, what kinds of things, because just because they're over-the-counter and we can buy them without a prescription does not mean that they don't have side effects that could really profoundly affect a person's ability to live independently in their home. And blurred vision can make a difference. And they're wearing their glasses and they can't figure out while their vision's blurred. A lot of older people are given Benadryl to sleep at night, which is very drying. And there's two things that happens with Benadryl. It's a great sleep aid. It doesn't leave them hungover in the morning, but over time it causes short-term memory loss and it causes dry eyes and blurred vision. So if you see the Benadryl in the medicine cabinet and they're having certain complaints, there might be a cause and effect relationship. Okay, so much for eyeballs. Let's talk about ears. Hearing. Okay. Hearing is real complex. And when someone is hard of hearing, and we just say, well, go get a hearing aid. Well, you know, the type of hearing loss makes a difference as to whether a hearing aid is even reasonable or what type of hearing aid somebody needs. So here we have this cutaway of an ear, and this is the part you see out here. This is the part that you're not supposed to stick a Q-tip in, but y'all do, okay? And one type of hearing loss can happen here in this external auditory canal. And that is with aging. You know, the normal earwax that we have, which is actually pretty soft, pretty moist, and pretty much has its own way of working itself out of the ear. But when we get older, we're just not as moist as we used to be. And that stuff gets drier. It doesn't work its way out of the ear normally like it used to. And then, you know, we got this syndrome with the Q-tip. Well, they're jamming earwax farther and farther down into the canal and gradually losing their hearing. So the first thing anybody needs to do is just go to the doctor, get their ears looked at, and see if the doctor just needs to take the wax out. I wouldn't recommend people, you know, this is one of those, do not do this at home, because you don't need people sticking little sharp objects down somebody's ear, you know. Because right here, this little piece right here is the tympanic membrane or your eardrum. Now rupture that, you can't hear anything either. Sound waves come in and they vibrate this membrane. This membrane vibrating knocks these three bones together, which transfers that wave back to this nerve complex, sends that wave to the brain, and the brain says, oh, this is this noise, and interprets it. We hear in our brain, we see in our brain, everything we do is in our brain. We're going to talk about our brain in a minute. Now, the next kind of hearing loss with aging, our bones get more brittle. They get less liquid. People get osteoporosis. So those bones deteriorate. So you might need an amplifying device to take those waves and make them bigger, because you got to rattle these harder to get the same sound because you don't have as much bone there anymore. Okay? So that's another kind of hearing loss. And then, of course, when you get back here to the nerve section, if you lose the nerve, there's going to be no transmission into the brain for interpretation. That might require surgery. It may be that the person needs the services of one of the deaf services, social services in town, to help them to learn to live now as a hearing impaired person. And those are diagnoses that need to be really made, physicians, specialists, neurologists, etc. But it's important that people hear. And those are some of the changes that can happen just because we're older. And I noticed some of you, I've said the ear and you start scratching your ears. Okay, let's talk a little bit about taste, because that affects people's appetite, their nutritional status, and we lose taste buds as we get older. And the older we get, the less taste buds we got. You get to be in your late 90s, you don't taste much of anything. I think all you have left are some taste buds kind of on the back of your tongue that really only sense things that are like kind of bitter. That would probably, I would kind of like a little bit of that malady now, because things are still tasting really good, so I'm tending to eat too much, you know. I really like how food tastes. I enjoy it. But taste buds decline as we age. So that becomes a nutritional issue. We're going to go into the details of how we can get around some of that. And then there's the issue of what medicines are people on. A lot of times medications, they leave residue in the tissues of our body, and one of the places they can leave their residue is in your tongue, and then everything tastes like you're eating nails, or it just all tastes bitter, and then nothing tastes good and people don't want to eat. And part of people getting well, if they're in any kind of rehab program and have any kind of potential to get better, is that they eat good food. And if it doesn't taste good, they won't eat it, and then their decline is just a spiral. Then we want to talk about the sense of smell. And interestingly enough, aging doesn't have a profound effect on the sense of smell. Most people lose their sense of smell if they have some kind of an accident. Now, I have heard of some people who have had cancer treatment who have had their sense of smell altered in that they really can only smell one thing and they smell it all the time. And you have to have some strategies because it drives them crazy that they keep smelling mint or they keep smelling formalin because some chemical has changed in their brain their sense of smell. One thing to keep in mind about the sense of smell that I think is kind of interesting is that you'll notice that when you walk into a place, you'll know what things smell like. But you're there for a while and you don't smell it anymore. And that's because we adapt to smells and we lose the memory for them very quickly. And that's very dangerous when it's fire. People in their homes in the middle of the night, if they don't wake up, if they don't have the smoke alarm, they'll smell it in their sleep, but they'll lose the sense that it's happening and they'll sleep right through it. They'll adapt to it, and that's how people get lost in fires in their home. So when people go into the home, it's a really good idea to look around and make sure there's a smoke alarm in people's homes, and maybe even a carbon monoxide alarm. And just one of those nice little things you can do for someone is tell a family, you know, you ought to get that in here because this is what happens with the sense of smell. And the older we get, we may sleep through that. Okay, let's talk about skin. We all know about skin. I told you, buy the wrinkle cure. Trust me, you need to do this. Well, we just lose elasticity and we lose collagen. And then when we don't have all of that collagen under there to plump things up, it all goes toward the earth. You know, whoever discovered gravity, I'd just like to strangle them. I know if they hadn't discovered gravity, this wouldn't be happening to me. But we get wrinkles. Now, according to the latest theory, our wrinkles are really caused by free radicals. We should be taking antioxidants like crazy. We also should not have a lot of sugar. Well, we're a sugar society, thank you very much. And don't tell me not to eat my sugar, thank you very much. But actually, sugar is very damaging to cells throughout the body. It stiffens cell walls and causes them to kind of break down. And that's supposedly part of the reason that it really is attracted to skin cells. And so when those cell walls stiffen and they're not supple anymore, that's where the fine lines come from, is all along those areas of cells that are damaged by sugar. White bread. According to the free radical antioxidant theory, we should be having lots of salmon and melon and high protein, and they've even taken white rice away from us. You know, they're not leaving us a whole hell of a lot here to eat, but to preserve our skin, and topical antioxidants. So we'll see. Medications can really affect the skin. And a lot of what happens with medicines is they make people sun sensitive to where people will actually get sunburns. Tetracycline and the tetracycline family of antibiotics are a classic for you go outside, little bit of sun, and you are at blister city. Lots of people who have had chemotherapy, even if they're not actively on chemotherapy, but they go out finally in the springtime and They get sun on their skin and they will have huge blisters. It's called a flare reaction. So I think it's a mainstay for anybody's medicine cabinet, the older they are, to have sunblock. And they now make these wonderful pump spray sunblocks so that it's not even that hard to put it on. I mean, someone can get out of the bathtub and every part of their body that they know is going to be exposed, just spray some of this stuff on to protect them from a sunburn. Because that can be really disabling. If they've got blisters, they're losing fluid out the skin because it's just like a burn. It really is a burn. So taking care of the skin is really important. The other thing about the skin in aging people is the older they get, the thinner it gets. You'll notice sometimes people look like it's tissue paper. If they're on prednisone, it's really like tissue paper. They can't hardly walk up next to something. I mean, they could walk up next to me, brush up against my jacket, and have it abrade their skin. That's how sensitive it gets. And that can become an issue. Somebody cuts themselves, and a dutiful caregiver wants to run into the bathroom and they want to get a Band-Aid and a little bit of stuff and put it on, and you can't put anything adhesive on that skin. Because when you go to take the adhesive off, you will bring all the skin off with it. So strategies for simple dressings can be very important. We'll talk a little bit more about those strategies when we talk about symptom management, but you get the Band-Aids kind of out of the bathroom, and you think about other ways of dressing small wounds. And you have to dress them because these people are vulnerable to an infection. And the skin is our main protection against infection, an intact skin. So skin care is really, really important. Now nails. We know that nails get thicker. They get more brittle. A lot of people who are older will get fungal infections under the nails. You'll notice, that kind of milky yellow or white that happens with people's nails. If they don't tell the doctor really won't treat it. And there are medications to deal with fungal infections, and they should get those treated and taken care of. As nurses, we never cut nails. And the older the person was, we really stayed away from cutting fingernails and toenails. If a person is diabetic, you really don't go near fingernails and toenails. Because if you get too close and you have a wound there, the circulation to the extremities in a diabetic person is very poor. That's why they end up with amputations. And an infection can happen there, and they wouldn't even know it, and they'll lose that limb. So you stay away from cutting nails on people. And the other thing is when they get thick and brittle, and you take that clipper there and you go to snap it, you'll get that thing shooting cracks all the way down the nail. You can just really create a problem. So you stay away from nail care. And if someone has particularly problematic looking feet, that's what podiatrists are for. And most insurances, if they don't pay for a podiatrist, it's kind of amazing how you can call an insurance company and you can say, if we cut these toenails and they have diabetes and this shoots down their foot and they end up with an amputation, you know how much that hospitalization is going to cost your company? And they'll go, cha-ching, cha-ching, and all of a sudden they'll say, well, we'll allow this visit to the podiatrist and we'll pay for it. Negotiate with them. You can get uncovered services covered if you can come up with this cost-benefit ratio. And the cost-benefit ratio is it benefits the insurance company that it's not going to cost them so much. And know that as a strategy, even in your personal lives. That's a really important thing to know. You can negotiate with them for your coverage as you need to. Okay, well, we got the hair thing. Hair gets coarse, it gets dry, it gets wiry, and most of us get gray. Unless, of course, we have a good hairdresser that we're willing to pay lots of money to, and then we just don't get gray. Trust me, I know this. Some people lose their hair, and it's interesting. There's as much baldness in women as there are in men. And I see people back here going, pointing to their heads. On the other hand, we lose hair where we'd like to have it, and we start growing it in places where we really don't want it or need it. Men get these really bushy eyebrows. Some women get bushy eyebrows, but we pluck. Hair, ears, nose. I mean, I don't know what this thing is. I don't think it's very kind at all. All this hair stuff sticking out of orifices everywhere. For the first time this year, I had to get my boyfriend his personal groomer, you know? And that was just a real, that dampened his Christmas because he had really been staving off getting, but I said, those are your hairs, honey, have got to go. And of course, women, because of going through menopause and losing our female hormones, we have these masculinizing effects. The next thing you know, we got mustaches, we've got beards, we're plucking out of here, and of course you lose your eyesight so you can't even see the hairs to pluck them anymore. That's just one of those horrible little facts of life. And I think it can be really a kindness when, we're sending someone into the home and they really pay attention to those little details of personal grooming. Because most of the people that we go in and take care of, they have an image of who they were that still is kind of playing in their mind. And it's embarrassing for them to have the chin hairs and the, upper lip darkening hair, or going bald, or whatever. And a little attention to how they look can make a big difference in how they approach every single day. It's just a little bit of psychology. So pluck the chin hairs, point them out to an electrolysis person, or have them go down and get their lip waxed. Just really encouraging them to get out, and I noticed that in the job description, some of these people can drive them places, set up those little appointments and take them, and have that day out where you get waxed and groomed and plumped and fluffed, and it makes so much difference in their own self-esteem. And self-esteem when you're aging is really important because society is kind of disregarding who you have been. They have lost sight of who you have been. And these are people who have had wonderful lives. They have probably accomplished wonderful things. They've raised families, they've had careers, they have been incredibly valuable. And now because they're old and not contributing anymore, they're very forgotten. And how they look was part of who they are. And I think keeping them looking as good as possible every single day is just one of the best things you can do for someone. That's a gift. All right, back to systems. Now, I want you to pretend that there's muscles attached here. Because really, the skeletal system doesn't do much without all the muscles that are attached to it. And there are changes with aging. And in those muscles, the muscle cells, they tend not to replace themselves very often. You're born with a muscle cell, you've got that muscle cell working for you for years and years and years. But they get stiff as we get older. They don't have the tone. They don't regenerate like some other cells in the body. We just kind of use them until they're kind of all hard and fibrous. And then what's really supporting our muscles are the still viable cells around that fibrous cell. I mean, just slowly, the different cells in the muscles begin to stiffen and not be as useful for doing things, all the things that we do. As I'm moving my arms, I've lost muscle cells, the strength in my legs, the ability to move, walk, lift a cup, lift a fork, brush my teeth, walk around the block, get in and out of the car. I have less muscle cells to do that the longer I live. What also happens is there's a fluid buildup between those cells that further impedes the ability for them to move and contract and expand normally. And of course, the best antidote for that is exercise. The more one exercises, the more one can retain their former abilities. And we're a sedentary society. I'm sure all of you now in your businesses, you're behind a desk a lot. You're manning a phone a lot. One of the biggest things you can do for yourselves is get out of there a couple times a day and take a walk. Move around, do some bend-overs. Go to the gym once in a while if that's what, if that's something you feel comfortable with. Exercise is really important. And the people that we're going into their homes, encouraging them to do something every day and not kind of giving in to their needs to be real sedentary. I don't feel like getting up right now. I don't want to do anything. It's one of the things that I really tell my family caregivers is never do for another adult what they can do for themselves, because that really fosters being an invalid. So if there is a way that your people can get to be kind of, I don't want to say manipulative, but if they can get a sense for a person's ability to do things and they don't pander to them and they really stand their ground and say, well, you know, I'm really busy right now, or I can't do that, or you need to do that, and really find ways, strategies that you don't do for adults what they can do for themselves, and keep them busy, keep them moving. Very important. Now the bones, well, we've heard the osteoporosis stuff. Women more prone to osteoporosis than men, okay? And one of the ways that we preserve bone mass is by bearing weight, walking, moving. That's what helps bones get the message that they have to keep making more bone cells, is when we move and stand. Right now, you're all sitting. This is not good. We'll get you up in a minute. Trust me. But the bones and in the spine, you notice back here, there's these little bands of light-colored stuff in between the bones. And that's actually some cartilage filled with some crab meat-looking stuff. And that just kind of dries out and shrinks, which is why the spine kind of compresses down on itself. And those are the place where if I want to do this, and I want to bend sideways and backwards like this, it's these spaces that give in between the bones that allow me that kind of movement. Once those spaces are gone, I can't bend or move or flex my spine to kind of get around. And so I'm shorter because I've lost that space in between each one of the vertebrae, and I don't have flexibility, and probably my back hurts. And what helps is movement. The more movement. Of course, once those are gone, movement becomes kind of a moot point because they really can't move without those spaces. But you all still have your spaces. So you are exercising, right? The other thing about the loss of minerals out of the bones, and of course we really focus, the bones are mostly calcium, but there are other minerals in the bones too. There's phosphorus, magnesium, other things that leach out. But they get to be just kind of porous, and they get brittle. And that's when breaks happen. The classic is the hip fracture. Okay, here's your hip right here, top of your leg. And this is what breaks right in here. And what's real interesting about hip fractures is that rarely are they the result of a fall. What happens is the bones are so brittle, and you bear weight that one time, this cracks, and then you go down. And then, of course, when you hit the ground, it further compounds whatever that fracture looks like. But it really is more the bone breaks and then the fall rather than the fall and then the bone breaks, which is kind of inverse to what we think about. But people taking calcium is real important. Everybody should take calcium. The older we get, the more we need our calcium supplements. And the calcium supplement should be with vitamin D in it. So watch what you're buying. And for some people who really are osteoporotic, and you can get bone density tests. I know they're having, most drugstores will do a bone density test. You pay $30 and you can go in one day and they're doing bone density testing. They'll tell you what your bone density looks like. And if it looks like you've been on calcium, the requisite good-sized doses for a while, and it still doesn't seem to be coming up into the bones, the doctor can give you other supplements, fluoride being one, that will really encourage the bone to take up more of the calcium instead of having you just flush it through. So there's other compounds that can be put together so that that calcium really gets put where you want it to be put. But it's what happens when we get older. Um, all right, our hearts, very important. Now, hearts and lungs are all tied together. And one of the things that happens with hearts, and the reason they work with lungs so well, is you have the circulation. The heart pumps blood that's been through the lungs, comes in here, and then it gets pumped back out. It's picked up oxygen, and it gets pumped back out here to all the parts of the body, taking oxygen everywhere. So all of our cells have something to work with. Now, once that oxygen's been used up, the cells put off byproducts that go back into the bloodstream, and it has to be reoxygenated because we've oxygen depleted it. So that comes back in here and gets sent out to the lungs. So that's why you have this double system in the heart. One side pumps out to the entire system, and one side is involved with sending the unoxygenated blood to the lungs to pick up their load of oxygen, comes back in and back out to the rest of the body. If someone is anemic, okay, not enough red blood cells, poor quality red blood cells are what carry the oxygen. You don't have enough red blood cells, you're not carrying enough oxygen out everywhere. Older people can get anemic because they don't eat right. They don't have good iron stores in their diet. So their heart will have to beat faster to make up for not having enough of the cells. It pumps up its rate. Their respiratory rate will go up. They'll be real tired. They'll be pale. They don't have energy to do anything. They try and do something, they're absolutely short of breath because it's like they don't have enough oxygen. And it's not their lungs at all, it's their blood. So if you guys, and they'll also feel very cold. So if any of you are having any of these symptoms, it's just an iron supplement, okay? The other thing that happens with aging is these blood vessels, they're real elastic and supple. But as we age, they get stiffer. And the other thing that happens is we eat all these wonderful things that we eat, like our butter and our milk. And in here, well, more like around the edge in here, lining that whole blood vessel is just, we kind of get this coating of sludge. That's the only way I can describe it. I know that's an ugly visual. But this stuff just starts building up along the wall of that blood vessel so it doesn't, it's thicker now. It's not supple like it used to be. It's not pumping blood as well as it used to be. The other thing that does is it raises the blood pressure in the whole system. So you notice that older people tend to run higher blood pressure than younger people. And part of that is because our blood vessels just aren't that supple anymore, and they're stiffened by these plaques, and it reflects in an increase of pressure in the system. So you have the vessel itself stiffens, you get this coating of sludge, and there's also, when our bones are decalcifying, some of those salts also line the inside of the arteries. And these are chemicals, these are crystals, which further stiffen and narrow where the blood can go. So if you let one of these blood vessels narrow off enough, and this shows what goes to the system from the heart. Outside here, there are blood vessels that have to feed this muscle right here. And those fill with sludge, and they get narrow. And at some point, if there's enough stuff that fills that blood vessel and plugs it off, then there's no blood getting to whatever piece of this muscle is beyond that point. And that's what heart attacks are all about. That's actually what strokes are about, only it's the blood vessels in your neck. And all of a sudden they clog off and nothing gets past it, and whatever brain is fed by that blood vessel begins to die. Okay? So that's kind of the mechanism, and the older we get, the more at risk we are for heart attack and what they now call brain attack. Now, congestive heart failure, #1 killer of adults in America. Okay? And congestive heart failure is simply the failure of the heart as a pump. all right? That's all it really does. It squeezes, contracts down, and it shoots blood through the body. But for some reason, for changes in this muscle, maybe they've had a couple of heart attacks, and once you've had a heart attack and you've got pieces of dead muscle that no longer contract and push, well, that's failure of the heart as a pump. It is not pumping as efficiently as it did. Only parts of it are now pumping. So that can be, and as congestive heart failure happens, the muscle tries to compensate by becoming bigger, but all it gets is kind of boggy and less effective over time. But that's really what congestive heart failure is. And the congestive part is that in these chambers, since the heart's not emptying them with every squeeze, there's residue of blood in each chamber that doesn't go out to the system, doesn't allow the stuff coming back in to come in, so it's sitting out here in the system. It's got to go somewhere. It's sitting there. Pressure builds up. Well, the next thing you know, the fluid leaches out into the tissues, and one of the first things you see with congestive heart failure is people with swollen feet and ankles, because all that stuff way down below, with gravity, it just goes in, the fluid goes into the tissue because the heart can't pump it. There's too much fluid and not enough heart muscle to move it. On the other side, that has to pump the blood from the lungs, and that backs up, that's where people get into that condition called pulmonary edema, where they kind of are gurgling, they're very short of breath. Well, that's the congestive failure on that side of the heart. Congested in the ventricle, back pressure into the lung. The vessels in the lung can't hold that much fluid, so it pushes the water out into the lung tissue itself, and they end up going to the emergency room, getting massive IV doses of Lasix to pull the water off, so that the heart can manage the volume of fluid coming through it as a defective muscle. Okay? Does that make sense to everybody? I know it's a complex thing. But lots of people that you will be dealing with have congestive heart failure. And it means low energy, shortness of breath, a lot of patience on the part of the people you're sending out there, because everything's going to be in slow-mo that they have to deal with. And you have someone who wants to go there, they're kind of task-oriented, they want to get everything done, but you got this person who is like sluggish and doesn't move, and it can get frustrating, and they got to reel it back. They can't go that fast. They don't have the heart-lung capacity to do that. And you just got to read the poem, Let Go, and remember that you're doing everything in slow-mo. And it may adjust the amount of time they have to spend with people. Any questions about hearts? Okay, and we talked about lungs. Well, let's show you some lungs. Now, the respiratory system really starts up here with the nose, down the trachea, out here in the lungs. That's kind of what they call the respiratory tree. So if you ever hear it referred to that, that's the system that they're talking about. Now, as we age, we've already talked about muscles get stiff. We have bones and cartilage that is demineralizing, stiffer, cartilage kind of stiffening and going away. And those muscles and bones have to expand and contract to drive the breathing. So if you are losing some lung capacity, you can see where people would have some problems breathing, okay, because the muscles aren't working that good anymore. So everything, again, is going to be slower, short of breath, more sedentary, and it's just some of the changes that happen. I think another thing that's important to know about is where we actually breathe. The exchange of gases don't take place in these big bags that are sitting in our chest. What we really have is the air goes in, but it goes into these little tiny microscopic little sacs. And that's where the true exchange of oxygen and carbon dioxide takes place, is in here. blood vessels. If you were to look at that, it would have this mesh all around it of arteries and veins, okay, capillaries. Where this makes sense is when we talk about emphysema, because this is where emphysema happens. It's these air sacs. And emphysema is a disease of not being able to empty the lungs. Most people with emphysema can inhale really well. They can take in big breaths. But because these are destroyed, and they'll have holes in them, some of them will be missing, and they only have a few of these little air sacs per square inch, the carbon dioxide just sits there, and they can't breathe it back out. And that's the disease of emphysema. And a lot of older people have that. Actually, every single person, whether you smoked or not, by the time we die, if they did autopsies on everybody, every one of us would have some mild degree of emphysema just because of what we breathe in and day out, that does, in the very bottoms of our lungs, air sac damage. But we don't have the degree of emphysema that really impairs our ability to get around and move and participate in activities of daily living. But for those people who have smoked all their lives, this is a nightmare. And once the damage is done, there's no replacing it. And it really does impair their ability to move and get around. They can't cough and expectorate things that are in their lungs because they don't have the ability to move things from the lung out. They can get things from out to in, but not in to out. So the coughing thing, very prone to infections, and at some point, they will all end up on oxygen at home. And this is one of those places where I think if you were ever going to consider what was going to be in services, is how to live with oxygen in the home. Horrible story. Happened in Lake County. Gentleman was sent home with oxygen. This isn't an attendant care story, but he was sent. He lived in a trailer. He had propane. He had very serious lung disorder. They sent him home on high-dose oxygen, which is usually not what people get. But when oxygen is in the home over a period of time, it creates an oxygen-rich environment. Well, one day he went in to cook himself some breakfast. He turned the pilot light on the stove and blew that trailer right off the lot. Oxygen's very flammable. And so you kind of have to have a sense. You know, some people on oxygen, we don't allow them to use electric razors because of there being possibility of a spark when they turn the razor on in an oxygen-rich environment. So, and you can maybe borrow some protocols from local hospitals, local home health agencies for if there's oxygen in the home. If it's delivered, the company that delivers it is supposed to post on the door that there's oxygen in this house and have written rules in the house. I can let you know that what they're supposed to do and what you walk into are two different things. Sometimes you'll find them there. It just depends. It varies from company to company. Some are real responsible, and some just dump the oxygen off, collect the check, and go bye-bye, and don't even show the people how to use the equipment. You know, maybe somebody needs to know how to change a tank. You know, a tank gets empty. How do we switch this person from tank A to tank B? Yeah. Would you repeat that?
Is there a device that measures the level of oxygen?
The question is there a device that measures the level of oxygen in a house? Not that I know of, but if you probably called a local respiratory care company who delivers oxygen equipment, they might tell you if they use something. But just, we assume that it's an oxygen-rich environment if someone has oxygen running. That's a safe assumption. And then the issue is about open flame and spark. And that's just a safety issue for all of us. Yeah.
Is there any, do they, before prescribing oxygen to somebody, do they even ask them to try to gas burners, open flame gas burners on the stove?
No, because when they're prescribing oxygen for someone, the person really needs it. You know, that's not something that they ever do lightly. What you hope is, when someone's going home with oxygen, there's going to be home health ordered to transition the person, And the theory is that somebody with some savvy will be doing a home assessment. But this man went home up in Lake County and nobody went there. He went home on oxygen, no home health order. It doesn't always happen the way it should. And it's kind of a crapshoot. So for our own protection and the protection of our clients, we kind of have to have a little bit of a heads up. Where's your instructions here for this oxygen? Where's the instructions for the machine? Do you have a concentrator or do you have O2 tanks? Where's the portable tank? If you're going to leave this house, am I having to haul a tank that's, as tall as I am, that weighs as much as me in and out of the car? Where's the portable tank? How are we doing this? And that can be a very real dilemma for someone walking in cold to help somebody who is taking them on errands. And how do I switch the tubing from this tank to that tank and making sure I turn off the big tank so that they don't run out of oxygen and we just have it blow into the air while we're gone. Oxygen is a deal. And, there's people in every community, respiratory therapists, pulmonologists, techs from respiratory care companies who many times will be happy to do safety in services. And it's not a bad idea to know who the American Red Cross is in your area, who does the first aid classes, the CPR classes, and a lot of times they will have some of those home safety classes that they offer, if not for free, for a very nominal fee. And I think those are just investments in your safety and security for your future, are those kinds of classes. Now, anybody know what this is? Aside from reading it? Close. It's a nerve cell. This is a neuron. What I think is really cool about neurons? That one of these can actually be, like I could have, this piece is in my brain, and this one will run all the way down, single nerve cell, all the way down to my foot. Some nerve cells in our body are that long, that big. They're really cool. Nerve cells are great. Now, nervous system. Brain, spinal cord, and then we have all these peripheral nerves that come out off the spinal cord and go down our arms, band around our body, go down our legs, so that we're just in tune, sensory and motor-wise, in our environment. That's where we get all our messages, is through our nerve cells. Most of the changes related to aging, however, are not about the peripheral nervous system as much as they are about memory and thinking and cognitive changes. What happened right up here in Message Central. Now, it was thought for a long time that neurons did not replicate themselves. Once they were gone, that they had no regenerative powers. But there's been some very interesting research at a very expensive building in Marin County that is looking like we do regenerate neurons. Some of them anyway, and parts of them for sure. Neurons are kind of cool. This part is kind of what takes in what the stimulus is and transmits it down here out to wherever it needs to go. And another thing that looks a lot like, well, actually the other end of this would be at the top here, and they transmit chemicals between each other. And that's how impulses are transmitted. It's all chemicals in that space. And this space around here and between the end of the next nerve cell is called a synapse. So if somebody says that you're acting like your synapses aren't snapping, that's what they're talking about. There's no chemicals being produced, and this is a black hole we're dealing with. But that's how most of the impulses that we have, our thoughts, are transmitted from nerve to nerve is through that space. And it's a lot of where they think Parkinson's disease is a problem because of an imbalance of the chemicals in that space. It's why they believe we have clinical depression, is because chemical imbalance in that space. what one cell puts out as chemicals and what another cell perceives, differences in that space. As we age, our brain gets smaller. In Alzheimer's disease, it gets incredibly smaller. We lose a lot of the creases and dips in between you know, our brain looks like cauliflower. We got a brain over here we'll look at in a minute. Not a real brain, honest. But you know how it looks like a cauliflower and it's got those deep valleys between all these wonderful folds, and that just kind of shrivels down. And people in Alzheimer's disease, they lose the gray covering, which is really where most of our thought and movement and what have you are transmitted. The white matter stays pretty much intact in the middle of the brain, but the gray matter just flattens out, shrivels up, and goes away. Why? We don't know. We know there's certain chemicals that people with Alzheimer's have a lot of called porphyrins, and whether that's a contributor of this disease or not, we're not sure. But you know, if your brain shrivels up, you know, we've seen the results. There's not much interaction. There's real disability. The other thing that can happen in the mental, in the nervous system is TIA or CVA. Anybody know what those are? Transient ischemic attack or cerebrovascular accident. Transient ischemic attack. Someone has stroke-like symptoms, but they go away by themselves. And that means that for a little while, an artery that was transmitting blood to the brain got clogged up for a reason, but it opened up by itself. Okay? They got lucky. But that's a sign that something in there might be going on, and if they act on it and they open that blood vessel up, you might stave off a stroke. Okay? And then cerebrovascular accident, stroke, or brain attack. Now, there's two things that can happen to create a stroke. The first thing we talked about, blood vessel closes off, brain doesn't get blood supply. The other thing that can happen that would cause a stroke is you get what's called an cerebrovascular bleed, where a blood vessel ruptures and then it bleeds into the area. Now, the brain is in a box. It sits inside this skull, and you start infusing some kind of fluid into it. Well, there's only a confined space, and it starts pushing tissue up against the brain case, and that blood hemorrhage in the head puts enough pressure that it gradually, with the compression, kills brain cells, and then you can have the residual of a stroke. So it becomes very important when someone is having those early symptoms, you know, like they can't communicate, they don't seem to be able to move, they go to lift their arm and they can't, that before you give them an aspirin and run them to the emergency room, or actually you're not running them anywhere, you're dialing 911, but they have to determine, is this an intracranial bleed or is it a blockage of an artery before they initiate treatment. Because if they give somebody the medicine that will reduce a clot and open the artery, and what they've got is an intracranial bleed, that medicine will make it so that intracranial bleed will not clot and make it worse. So that diagnosis within 3 hours is really, really important. Okay? Because there's two different ways you can end up with brain damage. And once the brain damage has happened, it doesn't matter what kind of a stroke they had. The treatment plan, the residual will be probably a paralysis, difficulty speaking, maybe difficulty swallowing, depending on which side of the brain was impacted. So you will do the same things for this person afterwards, regardless. But if a person happens to be there when it's going on, that first intervention of getting them in for medical help immediately as a 911 emergency is going to be crucial as to the outcome. Within 3 hours, they can reverse the effects of a stroke, regardless of what's causing it. So that can be just real important. Err on the side of safety, 911, haul them in if they're having something that looks like mental status changes. Okay. Well, we have the urinary system. What happens with that one? Well, those are a couple of kidneys. They're cute. Down here, you'd have your urinary bladder. I just couldn't get a picture of the whole urinary system. I couldn't believe this book could not include the whole thing. You got kidneys, ureters. Down here you have your urinary bladder, and then the urethra, which takes the urine away. Okay? Kidneys are great things. You can live with one of them, but you can't live without both of them. And as we age, the kidneys do get smaller. They shrink a little bit. And the blood supply to the kidneys, which is really pretty important because they filter all the blood through our body, the blood supply gets to be a little bit less. So people tend to not be getting as cleansing as would be good for us as we're older. The other thing that happens with the aging person and the urinary system is that, we talked about muscles getting weaker. Well, this whole system, particularly when we get to the urinary bladder and the urethra, relies on smooth muscles for its tone and for the control of the sphincter at the bottom of the bladder. And those muscles get weak, so older people, the more weak their muscles are, the more they might tend to just kind of dribble. The more children a woman has had makes those muscles weaker. And for men, the prostate gland sits, it rings the urethra at the neck of the bladder, and the prostate with age just gradually enlarges. That's not necessarily a bad thing, except if it enlarges inward and it begins to compress the urethra a little bit. Number one, a man cannot empty his bladder fully every time he goes to the bathroom. It gets overfull, and the pressure in that bladder actually forces urine through, and they dribble. And the other thing that happens with that is that over time, with that overfull bladder, the nerves in the bladder are actually damaged, and they don't get the sensation of urinary urgency anymore. And that leaves people prone to bladder infections repeatedly from having that urine be held in there. So those are some of the things that can happen with older people. There are surgeries that can repair these different things if people really can undergo the surgery or are willing to undergo the surgery. I'm a big fan of disposable underwear, and I'm letting you know right now we never refer to attends or depends as diapers. We do not diaper adults. They are disposable underwear. It's really, people don't want to be dependent anyway. And to be thought of as infantile is really kind of undignified. So it's disposable underwear. We don't diaper people. And every time I hear a nurse or someone refer to them as diapers, I correct them because I think it's disrespectful. So, disposable underwear. I don't think, renal failure. We better talk a little bit about kidney failure, because that really does happen a lot. Many people that we will take care of have diabetes. One of the long-term effects of diabetes is kidney failure, along with the blindness and the peripheral neuropathy and all of those things that go with diabetes, but they can lose the kidney function. That has implications for both diet and fluid intake. If your kidneys are not putting out the water you take in, it's building up somewhere, and it's not being filtered, and it's going to be a problem. It's going to back up into their heart. It's going to cause congestive heart failure over time. They'll become toxic, yada, yada, yada. So there will be very severe fluid intake restrictions on people who have kidney disease, and particularly if you hear someone who's on dialysis. The first questions you ask is, what is your fluid intake maximum per day? And they'll be thirsty and dry all the time, begging for something to drink, and they can't have it. And the other thing is that there are serious diet restrictions. It is the most difficult diet to comply with on the planet, is the kidney diet. So some dietitian has to have written somewhere what it is they can eat. And when we are sending people in who are specifically, one of their biggest things is going to be about cooking and fixing food and going shopping and doing all of that, and you're hit with somebody who's got real serious dietary restrictions, you need a list of what they can eat. And that's what dietitians are paid the big bucks for. And if they don't have something in that home, that's the time you say, well, you know what? They're not doing you any good service by not supplying you with sample meal plans and a list of those things you can eat, because they can't, there's certain calcium restrictions, there's phosphorus restrictions, there are magnesium restrictions, and all of those things are found in vegetables, dairy, things that we really have incorporated in an American diet as staples, and they can't eat them. So that's the little mini research project if somebody has kidney disease. Okay, now we have a GI tract. Gastrointestinal. That starts with, oh, I got it in backwards, okay. Mouth and teeth, down the throat, down the esophagus. We got a stomach here. There'll be a liver, there's going to be a gallbladder, a pancreas, a few other little things in the middle here. Dumps into the small intestine, which is this sausage-looking thing right here, and then small intestine into large intestine, and then out the anus. That's where food goes. And where we really eat, we may chew it, we may dump it into here where it kind of gets processed and liquefied, but we eat in here. That's really where our nutrition comes to us from. Liquefied, broken down into its component parts, and then absorbed through the intestinal wall into the bloodstream, then taken around to all the cells for nourishment. Now, the large intestine, kind of an interesting little critter, goes in here. The first half of the large intestine is meant to recycle our water. We are a recycling organism by nature. So it recycles and pulls out all the water we used to break that all down to liquefy it, return it to the system, and then the remainder out the rectum is really the waste. Now you can imagine what this means if somebody has diarrhea. Okay? They're not reabsorbing their water, and where water goes, so goes a whole lot of micronutrients that we need. So immediately fluid intake issues. And the other thing is, what's the irritation? What's going on here? And if it's going through that fast and coming out liquid, how much are they absorbing in here? You know, we got some nutritional issues here. Not that anybody needs to diagnose that, but it's just kind of a heads up. And of course, they got diarrhea, you're giving them lots of water. One of the things that's real common happens right up in here. We have a muscle at the top of our stomach that basically, when we swallow our food, it dumps into our stomach, and this muscle slams shut because really we don't want anything to go back up the other way. This is a one-way system. Well, heartburn, that's reflux backwards up this muscle, up into here, okay? If this muscle gets really stretched and pulled, that's a hiatal hernia. So some of the considerations for that are that when you feed somebody, and particularly if you give them food and then you give them lots of liquid to drink with that food, a couple of things you want them to do is sit upright for at least 2 hours after they ate it, and you want them to sit in a chair that's not sunk down too far, that causes this stuff here to push up on the bottom of the stomach here, which can literally propel the stuff back up here. People eating their evening meal, they need 2 hours between when they eat their dinner and when they're going to go to bed. And if they're kind of bedbound and sedentary, if you're going to lie them in bed, they need to have their head elevated for 2 hours to prevent the reflux. Okay? Got that? You're all ready now to just march into their homes and go, okay, fine, you're not laying down for 2 hours after you eat. Right. But that's the whole concept of hiatal hernia and some of the little, preventative stuff from problems. Mouth and teeth, we all know that teeth erode. Gum disease starts at middle age. There's some company in England, and I wish they'd hurry up, they're actually coming up with a vaccine against the bacteria that causes gingivitis and gum erosion. So people coming behind us in life will actually not have the tooth loss and tooth destruction that most of us end up living with as a process of aging. And the bacteria that's causing that gum disease is also largely responsible to the bad valves that people have. It's the same bacteria that causes valve erosion in the heart. So keeping the mouth clean is really important. Some hydrogen peroxide water rinses, and we'll talk more about that later. And obviously, the other complications can either be constipation or diarrhea. You know, there's muscles. See, each one of these indentations here is actually, there's a muscle band inside the intestine, smooth muscle, that has to constantly contract down in a rhythmic forward motion to keep things passing through the same direction. Well, the muscles weaken, they stiffen, they don't work as well. People who don't drink as much as they used to, don't exercise as much as they used to, constipation and or diarrhea can be a problem, to say nothing of what meds are they on. Some medications will contribute very much to diarrhea. Matter of fact, if you look up any medicine in the PDR, 90% of them will read as their first 3 side effects, nausea, vomiting, and diarrhea. So, and you're looking then at the little pot of medicines that these people are on, you might be running into nausea, vomiting, and diarrhea. Bet on it. And of course, constipation is a biggie. A rule of thumb in nursing, someone should have a bowel movement at least once every 3 days. Might be one of the little charting things somebody wants to do is keep track of and not wait until it's Sunday morning at 7 a.m. and they haven't had a bowel movement for 6 days and they're going to the ER for enemas till clear. That's really ugly. You don't want to have that happen. So, you know, when was your last bowel movement? Legitimate question if you're a caregiver. And then what is the plan if they need a little help to have one? So finally, I want to talk a little bit about cancer, common problem over 65 age group. Cancer is basically a disease of wayward cells. They grow out of control. They do not have, they are immortal. They don't have what's called contact inhibition. Normal cells are great. They stay in their own little neighborhood. You know, they grow next to each other. They're happy little neighbors. They all look alike. Actually, normal cells look like those rows of houses in Daly City, you know. And then I think of cancer as the Winchester house. And the other ability of cancer cells is that not only will they just invade surrounding tissue, you know, they'll just grow right into whatever's around them, but they also don't stick together in nice little neighborhoods. They, as blood goes by, or they're irritated in any way, they'll slough off, get in the bloodstream, cruise around for a while, get stuck up somewhere, and start growing wherever they land. And that's the fundamental concept behind metastasis. Why somebody will go along for a while, look apparently disease-free, and then all of a sudden the same cancer crops up some other part of their body. And the treatment for this, of course, is very complex. For every type of cell you have in your body, that's a type of cancer that has its whole particular pathophysiology, its own particular treatment plan attached to it. Not all cancers are treated with chemotherapy. Some are resistant to chemotherapy. Not all cancers can be treated with radiation because they're resistant to radiation. Sometimes they'll respond to combinations of both. Some, if you don't get it with surgery, you're just kind of a dead duck. So it's real important for the patient to certainly know what kind of cancer have I got, what's the treatment plan for it, and then as soon as the treatment plan has been decided, they should have some instructions about what are going to be the side effects of this treatment plan. And those are written. They're handed out. I was a cancer nurse for a gazillion years. I sent this stuff home with people. Somewhere in the home should be a list of expected side effects and strategies about what to do for them. I included in your book, in the section on symptom management, a lot of real detailed, if you have this symptom, things that you can do for it, that will come into play very nicely if cancer is the disease you're dealing with and people are under active treatment. But it is just a real common disorder. And the system that's involved with the cancer is, of course, most likely the signs and symptoms and problems you'll be dealing with. But like it shows here, it's out of control and can go anywhere in the body. Diabetes. Now, I want you to read the section on diabetes that I wrote. I'm not going to go into the details. It's way more complex than just don't eat extra sugar, okay? It is really about the whole metabolism and the interaction between breaking down fats, carbohydrates, and proteins, and the balance that they need to be in order to maintain blood sugar levels. what happens in diabetes, it's a problem in the pancreas most of the time. And in order for us to get sugar into our cells, because that's really what the fuel is for our cells, is glucose. And glucose is a big molecule, and it doesn't go through the cell wall by itself. It can't get into the cell unless insulin is attached to it, and insulin does something that causes the cell wall to kind of open its pores and allow the glucose to go in. So what happens to people with diabetes is they're not making the insulin, and the sugar's circulating in their bloodstream. It's coming out in the kidneys, and their cells, they're tired, they're thirsty because they've got this sugar concentration in their blood, and their blood's sending a message to the brain that says, dilute me. So they drink water like crazy, and of course the more they drink, the more they pee, because the kidneys are going, it's too much sugar here, we got to pee this out of here. And they're starving to death while they're eating, because the whole reason we eat is to get glucose to the cells so the cells can do their job. So that's the underlying pathophysiology with diabetes. And people who have it will usually be on insulin. Are they taking their insulin? Did they take their insulin and then remember to eat? Because the other side of it is, if you don't have the glucose in there, the insulin will cause you problems floating around with nothing to attach to. And they can get very sick and die from insulin with no food. So there's this constant balancing of insulin and then their food. And how many times a day are they getting insulin? How many times a day do they check their blood sugar? Are they eating the requisite calories? And there should be a diet. The diet is prescribed by the doctor for X number of calories balanced out at each meal and snacks for the right ratio of protein to carbohydrate to fat. And they have to eat that, okay? And these are people who are going to be fixing their food and shopping for them. Knowing what that diet is really important. And then that they're getting their insulin. And the other thing is, insulin's kept in the refrigerator. But if it ever freezes, it's ruined. So keep in mind, frozen insulin is dangerous. They need another prescription. It may well be that if it can't be filled within a really reasonable amount of time by the pharmacy, that they have to call the doctor and come in and get an insulin injection until their prescription is ready. It's very critical that they get their insulin. Okay? And cirrhosis. We have a liver here. This is not a cirrhotic liver, that's a cancer liver, but cirrhosis is something that can happen most often as a result of long-term drinking. But the bottom line is that our liver cells gradually get stiffer. You know, liver detoxifies everything. All our medicine, you know, any byproducts in our food. You know, the liver's really responsible for keeping everything clean and clear. And over time, we tax that little liver. I mean, you know, think about all the partying we have all done. And our liver just, it's amazing. It just hangs in there. So it just gets stiffer, it enlarges. For the most part, unless someone is really an acute alcoholic or taking lots of drugs or has like hepatitis C or B or D or F for that matter, that's active, most of us will have few changes in our liver, but our liver will keep working for us up till the very end. But it does change. It doesn't detoxify as well. And those people who have liver failure, remember, if it's not detoxifying things and they keep taking their medicine and it's not clearing, it's just building up in them. And then it can be toxic. But our livers do change with age.